All right, I think we can go ahead and get started. Thank you all for joining us today for our Models of CL Services Psychologist Scope and Practice. This is hosted by the Society for Health Psychology's Consultation Liaison Interest Group. My name is Anastasia Bullock. I'm a representative for the Consultation Liaison Interest Group leadership team. And before we begin, we have a few items to share. First, this and all of the Society for Health Psychology virtual presentations are offered as a free benefit of membership in the Society for Health Psychology. Please invite your colleagues and students to join to ensure unlimited access to future presentations and other society benefits. You can visit our website at societyforhealthpsychology.org for more information. And this event is being recorded. So anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. After introductions and an overview of the different models that some of us practice, we're going to break out into smaller breakout groups for the 3 different groups of speakers, and then have everyone come back together at the end. Questions will be taken at the end of the presentation, and you may submit them via the chat feature during the presentation, or you may unmute and ask your question. And now I'm honored to introduce our panelists. Dr. Lauren Bigham is an assistant professor at the Medical College of Georgia and director of psychosocial oncology at the Georgia Cancer Center. She will be speaking to us today as a psychologist serving a specialty medical department, both in the inpatient and outpatient settings. Dr. George Scott is a postdoctoral fellow in clinical health psychology and neuropsychology at Chicago Pacific founders Stuart J. Nathan and Associates Outpatient, as well as an assistant professor in the clinical psychology program at Sam Houston State University. And Dr. Stuart Nathan is CEO and partner of Chicago Pacific founders and Stuart J. Nathan and Associates Outpatient. Dr. Scott and Nathan will be speaking to us today as psychologists in private practice with medical privileges at a local hospital to respond to in-house consults. And my name is Dr. Anastasia Bullock. I'm the lead psychologist for hospital-based psychology at Cooper University Healthcare in Camden, New Jersey. And I'm also assistant professor of medicine at Cooper Medical School at Rowan University. I'm going to turn it over to Dr. Lauren Bigham to get us started.
Hi, good afternoon. Thanks for the introduction. And let me see if I can share my screen. And what I'll be doing is talking more about what does CL kind of define our variables, so to speak, our constructs. Can you all see that okay? All right. So what are we really referring to when we talk about consult liaison, psychiatry, or psychology? We hear consultation all the time in our field, and certainly liaison as well. But let's explore this further. It's actually a subfield that specializes in offering more comprehensive services to patients with comorbid medical or and psychiatric concerns. It's really combining many of our identities. We serve as a consultant and really offering assessment and intervention to patients. Usually the context for CL, psychiatry or psychology, is inpatient medical units or surgical units. We also are able to wear our liaison hat in that we, another big portion of the job that we do is offering that rapid, fast-paced kind of communication, education, recommendations on how to better provide care for a patient in one of these units. CL historically began with psychiatry. And while psychology has been involved in this, it's becoming more common. And I'm appreciative for this group so that we've been able to get to know more CL psychologists And through that process, we've really identified that there are so many more models, structure, home departments, billing processes. There's a lot of variance here. So this is a great opportunity to talk through how it's offered by other psychologists from around the United States. So if you all don't mind, I'm going to go ahead and discuss how we do it here at my institution. All right. I work at the Medical College of Georgia. My primary home is actually our Georgia Cancer Center. But I have a dotted line to the Department of Psychiatry and Health Behavior. So I'm an assistant professor through psychiatry, but my clinical home and who I get paid by is hematology oncology. So what does our structure look like? That we're kind of housed in a couple of different places. So hematology oncology, I direct our psych onc service. And yes, we have a branch or an arm of that service that's in the ambulatory setting where we offer individual, couples, assessment services and interventions. We also have a second branch, and it's actually our inpatient CL service. This is pretty common for cancer. It dates back to Sloan Kettering, founded by psychiatrists who did a lot of CL psychiatry in cancer care. Many of our attendings here train at models like Sloan, and so they really wanted to make sure that these services were also offered on the inpatient side as well. So our inpatient CL psych service, run completely by psychologists, includes our attendings, our licensed psychologist. We have a psychology fellow here, psychology interns, as well as right now, we're thrilled to be welcoming a psychiatry NP student on our service. We're unique in that we are in both inpatient and outpatient, so we dedicate 2 days a week to the inpatient side and the remainder of the time outpatient. But if something emergent arises over in the inpatient setting and scheduling allows, we may sneak over there if necessary on one of those other days. Not to make matters even more confusing, our hospital was just bought out. So I am an assistant professor in psychiatry. I work for our cancer center and I'm under hematology oncology, but our hospital is now MCG Wellstar Health. So 478 bed hospital. On our service, we see anyone who's referred to us, but they have to be adult and with a prior or current diagnosis of hematologic or oncologic concerns. Services that refer patients to us most commonly are cancer-specific services over in the hospital. We have a solid tumor service that also cares for our hematology patients like sickle cell or hemophilia. We have a large transplant program. So they have actually 2 services that we receive referrals from. Gynecology, oncology, surgery, oncology, and then also our hospital service. But what's unique about us is we don't just stick to our units, our cancer floor, but truly any team in the hospital, as long as it's a patient with a prior or current diagnosis of a hem-onc diagnosis, we'd be glad to step in and assist if there's an appropriate referral or consult for us. So given that we're 2 days a week over in the hospital, give or take, over the past 6 months, our our productivity or our efforts have included approximately 125 consults and completed 215 kind of follow-ups or returns, and offering brief therapy, education, referrals, so on and so forth. What's an appropriate referral to us over on the inpatient side? It can range. As a psych onc service, kind of under that umbrella of health psych, we really utilize that model. So patients who are having difficulty with stress and coping, anxiety, depression, especially related to their medical concerns or impacting their medical concerns, risk assessment, suicidality, grief and loss. We see that a great deal. But of course, anything similar to health behavior change, sleep, adherence. We assess for cognitive changes up on the inpatient units as well, decisional capacity, treatment decisions, and helping patients make those, or even pre-transplant or pre-surge evaluations. How we receive our consults, it's a bit of a work in progress, whether we get a message through our secure messaging system, emails, phone calls. We're working on automating this through our electronic medical record. We're switching over to Epic in October. And from there, following up with the team, asking for more specifics on the consult, what are their concerns, really clarifying things to make sure it's an appropriate referral for us. See the patient, identify a treatment plan, recs, conceptualization, and then from there, quickly following back up with the referring medical team with any information or recs that education that might be helpful. Quick turnarounds, our hospital bylaws require 24 hours between submission of a consult and completion of it. And very quick turnaround on documentation as well. I think that kind of encompasses our service here. And I'm thrilled to hand it back over to Dr. Bullock in order to talk about her service and structure. And let me stop sharing my screen.
Thanks. Okay, so I'm going to talk a little bit about our service here at Cooper. We are fully made up of CL psychology team. We have a CL psychiatry team that's separate. Obviously, we work together with them and collaborate. Excuse me, but we've delineated our scopes and have agreements with various teams that we work with in order to make sure that we're kind of all being as efficient as we can. So Cooper University Healthcare is in Camden, New Jersey, right across the river from Philadelphia. We serve both rural and urban communities. It's a medically underserved area in the city of Camden itself, but we serve all of South Jersey. And South Jersey, for those who aren't familiar, is pretty diverse because it's pretty rural the farther south that you get, and there's actually a dearth of mental health resources throughout most of the middle of that part of the state. We have 615 beds. It's a level 1 trauma center for adults, level 2 trauma center for pediatrics. We have a neonatal ICU, and we have several ICUs, a medical ICU, a neuro ICU, a trauma ICU, and a cardiology ICU. So we are split up, and I'm just going to share my screen briefly. So we're set up in a way, because we're very lucky, it's unique that we have all these psychologists working together under this service. Over the years, we've worked with various departments who have been super utilizers of our service and have become like key stakeholders. And for that reason, they've had their own dedicated psychologists. So our general team that will take any consult that comes in across all of the departments in the hospital, we have about 4 psychologists. 3 of us have some established admin time for other roles that we serve on. We have externs, interns, and postdocs that contribute to the team, and a variety of people who are there on a daily basis. Then we have psychologists, and I think a few of them are on this call, who are what we call like the specialty teams. Some of them have some outpatient time. So our psycho-oncologists and our addiction medicine psychologists, they have outpatient days, and they have a couple of inpatient days. And these psychologists serve trauma surgery, oncology, critical care, the emergency department, and addiction medicine. Over the past 6 months, we've had about 2,500 consults. That's a variety of both, new consults and intakes, as well as follow-ups. So moving away for just the general team structure, we do see people across the lifespan. We have a smaller pediatric population here all the way up to end of life, as well as obviously seeing OB-GYN, moms, parents in the NICU. And our team, similar to how Dr. Bigham described it, is, we're really focused on the hospitalization as well as medical concerns. How is this person's functioning affecting their ability to participate in their treatment during this hospital stay, as well as what might be contributing psychologically, medically to their current presentation to the hospital, like adherence or something like that. So adjustment to new diagnoses, distress related to being in the hospital, pre-existing anxiety, depression, trauma that might be impacting their ability to manage being in the hospital, coping with chronic illness, pain, sleep, adherence, as well as behavioral care plans. So when people are having difficulty participating in their care, abiding by policies, speaking respectfully to people, a lot of people have difficulty getting their needs met in the same way they would outside of the confines of the hospital. We also get involved in that. We receive the consults through Epic. We use a combination of a consult phone, email, and Tiger Connect, which is a HIPAA compliant texting app that any provider or nurse can reach each other through that system. We also have service agreements. I mentioned this with psychiatry. We also have them with palliative medicine and addiction medicine, because as you can imagine, for a variety of those services, all of us could be co-consulted, and we just want to make sure who makes sense to get in the room first, rather than duplicating services. We live in the hospitalist department. Our argument is similar to our internal medicine colleagues who are kind of seeing people across the hospital and managing care, that we fit that, which I know is unique compared to a lot of people who live within psychiatry. Our productivity is measured through RVUs using the MGMA benchmark. We also use a scorecard. I'm happy to talk more in depth about that. That kind of loops into defining success and value and incentive plan. I'm happy to talk more about that during the breakout groups. Our billing practices really is to support and make that benchmark to support our funding and our salary. That's about 25 to 30 patients a week, with a variety of like 90791 psychotherapy sessions, crisis psychotherapy, and H&B codes. And yeah, I think I'll turn it over now to Drs. Scott and Nathan. Happy to touch more on that in the breakout room.
Thank you, Dr. Bullock, and hello, everyone. I will be very brief. I'll let Dr. Nathan do the heavy lifting on this. And I just wanted to add to the mix of the CL type services. As a recently graduate from my doctoral program, I was housed in a general hospital setting, and I'm still programmatically associated with them. I do a lot of the program evals for them. I'm not clinically active there, but it was what I like to call the enhanced CL model, and where we do typical consults, which Dr. Bullock and Dr. Bigham have already discussed. But we also did standing orders in certain high impact units, so cardiovascular ICUs, and we were like the immune system. We would just rove the units and do standing orders, and that was a 100% pro bono service. It's staffed by the coordinator psychiatrist. He's not practicing. The supervisor, neuropsychologist, clinical psychologist, and then practicum students and interns. And it's a little different. And so if anyone has students that are considering going to Puerto Rico for training, the setup is a little different. There in Puerto Rico, once you graduate, you don't have to do postdoc. You can start practicing immediately. If you decide to come back to the States, you're in this gray area. So you have to do postdoc here, but not there. And so you kind of, and so I'm here now in the States, in Houston, and I'm with Dr. Stuart Nathan in a private practice setting. So Dr. Nathan.
Great. Hello, everybody. So my practice started quite a number of years ago when consultation liaison was really in its infancy. In order to do CL work, you really had to find a medical psych internship within the VA system. There weren't a lot of them, but they were out there, or associated with a medical school, but there were not many positions that were available. It's nice to see over my career, which has spanned over 30 years, seeing this becoming a real legit subspecialty for psychologists. There still are not a lot of people who go into it. They don't get, I've seen the graduate programs, they don't train a lot. Psychologists are uncomfortable oftentimes working in a medical setting, working with medical patients, but there are tremendous opportunities there for all of us working in this environment. I ended up building a fairly large practice in the Houston area that we have since expanded to Nevada and to Arizona, primarily growing in the Las Vegas area or throughout the city of Houston. We consult in a number of medical surgical hospitals through different systems, local and national. We consult with HCA, Hospital Corporation of America. We do a lot of work with the Encompass Health System, formerly Health South, Post-Acute Medical Rehab, which is a group out of Dallas, but they're expanding nationally. And we're probably in about 15 different hospitals where we are the psychology group in the building. We do consulting with psychiatry when psychiatry is available. Typically, it's in med-surg that we get to work with them. We don't see many in the outpatient, in the acute inpatient rehab setting. It's tough for them to get them to come because the volume of cases that they see is small, and the volume that we see is pretty great. The typical rehab unit that we're working on is anywhere from a 20-bed unit to a 60-bed unit. And we see everything from strokes, cancer, amputations, traumatic brain injuries, major trauma from work accidents, automobile accidents. We'll see cardiac bypass patients and just the typical, little old lady, little old guy who fell at home and broke a hip. But there's a lot of adjustment issues for these people who have an elderly spouse who are not able to manage them. And there's the anxiety of how they get home, managing the adult children with the expectations, who can do what, and where the limitations are. We're a fee-for-service model. So in order to do that effectively, working as an independent consultant in a hospital, we are on staff, but we are not employees of the hospital. So we have to get credentialed in the hospital as an independent provider. To do that, pretty much any hospital you work in any state in the country, it's a 3 to 4 to 5 month process to get credentialed. There is no fast track. There used to be, but there is not a fast track any longer. In order to get credentialed in many hospitals, you have to have a physician sponsor you if you're going to be an independent consultant, which I've always found interesting because if you're an employee of a hospital, you can work tomorrow. But if you're going to be an independent consultant, it's going to take you months to get credentialed to do exactly the same thing as if you were an employee tomorrow. We're on every major insurance plan. You have to be on plans if you're going to work as an independent consultant in a hospital. You can't have a cash pay practice in a hospital. The physicians won't refer to you. The administrators aren't going to like you. They don't want us building a huge financial burden upon a patient who's just had a stroke, who's just had an amputation, who's had whatever medical issue that brings them there. We accept Medicare, all the different Medicare replacement plans, and work closely with patients, making sure that the service we're provided is something that they're able to afford. We get a consent for everybody when we're in the hospital. We don't just pop in and start treating without getting the patient and family consent. A lot of the work that we do is adjustment issue to the various medical problems that we see. We'll see SUD patients. We'll see people with major mental health issues that are pre-existing that we help to manage so it doesn't interfere with their rehab goals. We will see patients who are really doing well with the families decompensating. So we do a lot of work with family members within the system. We participate in multidisciplinary team conferences, every building that we work in. That's where we generate a lot of our consults. In some of the hospitals, based on the census, we're a standing consult. And some of the 20-bed units, we're a consult on every single patient that comes in. And then we treat as needed. We used to do a 3-day-a-week model, sort of a Monday, Wednesday, Friday. And then we expanded it on certain buildings based on the patient demographic to a daily service. Just as they get physical therapy, occupational therapy, speech therapy, and medicine sees them daily, we put our service in as a daily service. There are patients that we sign off on. If we think they're adjusting fine, they don't need any further service. We provide neuropsych services in the hospital, but limited because of the amount of time it takes to do the evals. And the programs don't want us taking patients out from the primary reason that they're in rehab, which is functional recovery. So we work around their schedule. With the model we have, there's lots of flexibility. The upside is there's no administrative tasks really to do other than your documentation, which must be done daily. My documentation is done before I walk out of every building. So that's the expectation. It can't show up in a chart 2 days later, 3 days later. Your charts are being looked at electronically each day when the attendings come in or the consultants come in, and they actually read our notes, which is somewhat refreshing. Not all of them, but you'd be surprised who does. And all the ancillary services, they all read our notes and value what we do. So we found it's been a really nice model. I've enjoyed having people come to the practice and join our practice who don't necessarily have the background and training formally in grad school. We'll train them. We'll make sure they understand what the model is, that they're comfortable in the work, and it's a great place. Not honking the horn at our practice, but it's a great place for people who are looking to do this type of work. We're very open to bringing people in and training them and giving them this expertise, and they either stick with us for a long time or they move on and do something else. But it's a field that we have really grown. We're known in the city of Houston. We're the largest CL psychology practice in the city. This is a city of 4 million people. So we've made our impact, and we don't have to convince hospitals to use our service. We just need enough staff to be able to service the hospitals who are requesting us. So that's what we've done over the years.
Thank you so much. Appreciate that. Okay, so now we're going to invite you all to join one of the 3 breakout rooms for a more robust discussion based on the interest in these models. And for example, like you might choose to go to a breakout group with Dr. Scott and Nathan because you're in private practice, you have questions about their model and how to move forward with that. So I think Steph is going to help us facilitate that. If you see down, you should see a little option to join a breakout room. Join it, and then we will come back for questions. Thank you.